Okay, so here's going to illustrate the utility of the Progreat 2.0, or Progreat ALPHA. So here's a right internal iliac artery and ipsilateral oblique. What you can see here is, again, just kind of review, because the more you see, the better. So here is going to be your umbilical artery, superior vesical artery, obturator artery, internal pudendal artery, and somewhere in between that internal pudendal and the superior vesicle here is going to be your prostate artery. So that's coming off of your internal pudendal artery. So got into the prostate, you can see this pudendal collateral, okay? So we're going to have to go in and embolize that. This is actually a magged up image, so it looks pretty big, but this next picture you're going to see, you need a microcatheter that's going to get out there pretty far. And this 2.0 Progreat is really nice because it's, first of all, it's as trackable as the other Progreats are, and it's small size. It can accommodate to 500 microsphere particles, and it'll accommodate any 018 microcoils, including the HydroCoils. Again, you need an 016 wire, but now you can use the 016 GT. And it's a high pressure catheter, so you can actually get 750 PSI. This is interesting. So the coils that you use, does it actually matter? And I don't have the answer to this, but I just bring this up because here's an article in Press and JVIR. And they looked at midterm recanalization after embolization with HydroCoils and fibroid coils in an animal model. And what they showed was there were significantly reduced recanalization rates with HydroCoils as opposed to fibroid coils at 1 and 4 months. And what they did in this in an animal model, I forget if, I think it might have been a sheep, I don't remember, but they went into the renal artery and then they embolized. This one was with fibroid coils. So they took 018 fibroid coils. The top left picture, A is pre-embolization, B is immediately post-embolization, so you can see there's occlusion. They did a 1-week angiogram on the bottom left, which showed persistent occlusion, but then at 1 month, they showed that the renal artery was pretty much completely recanalized. So then they did sections of these arteries, and they looked, and what you can see here is these black, let me get in here, these black things here, those are the fibroid coils, okay? And these asterisks in this big area right here, that's all thrombus that was formed. And then these little spaces here are areas that were recanalized in the vessel. And what you see here on the HydroCoil is these black spots are the actual metal coil, but the white is all the hydrogel material that expanded within the vessel. And this asterisk, you can see there's far less, you can see there's far less thrombus formation within the vessel, and there's smaller rates of recanalization. And the presumed cause was that the recanalization was due to these areas that had thrombus formation and weren't actually packed with plugs.
Quick question. So if you see that vessel that you want to catheterize, I assume you had a 2.4 French catheter there, and then you exchange. How are you now transitioning to the Progreat ALPHA? It's not your number one choice.
No, I actually do sometimes go with the Progreat ALPHA. What I kind of do is,
that example you just showed, what was that catheter? And then it was very small. So then do you exchange over a wire, give up your access? What do you do?
this one was, I had a 2.0 to begin with. Oops.
So that's a 2.0 there?
This is a 2.0.
That's a 2.0, but the image before where you see that branch that you want to embolize, is that a 2.0?
Yes.
And so that's your catheter of choice now, the ALPHA?
I often go with an alpha, yeah. What I'll do is I'll kind of say how big their prostate is ahead of time, and I'll kind of decide which one I want to go with. More and more I've been using the alpha just because I can get the same pressure injection, and I find it just as trackable as the 2.4. Anyway, here was the cross section. Now, does it matter? I don't know. Does permanent occlusion matter? I think that's something that we're going to have to figure out in the future, and I think that's a question for resorbable embolics versus permanent embolics, and whether or not this permanent occlusion of your collateral vessels really matters. And I don't have the answer to that, but I thought this was interesting. So we got down, coiled the pudendal collateral, and was able to safely complete the embolization. So go to the other side, ipsilateral LAO, so you can see the prostate artery, which we got into, successfully embolized. I'm going to go through some of these a little quick. So The rate of injection, this just show you the rate of injection really matters when you're doing embolization. I tend to go into the prostate, I'll do like a 1 for 3, 1 for 4, but you can kind of see as many collaterals as you want. I mean, if you do a hard enough injection, you're going to open up these collaterals. So the image on the left, you can see that we've opacified a collateral, but when I go in and do a lighter injection or even a hand injection, I'm not opacifying that. So I'm actually okay with embolizing here as long as I don't see that start to open up during the embolization.